What's going on, everyone? I'm gonna give it a minute, let everyone kind of come on in. So today, I'm gonna be talking about hip impingement. So we have a Prehab X group in which we have our members basically post topics in which they think are interesting or want us to talk about more. And what we figured we would do is post it actually on our Facebook and our Instagram, as well as YouTube, for an Instagram or Facebook Live. So I'll let you guys come on in. So today's topic is going to be hip impingement. The main purpose of this is going to be to talk about progressions, regressions of exercises, and how you can approach intervening on someone that has hip impingement. But I'll briefly talk about the pathology. So feel free to drop questions throughout this entire thing, but realize that we're prioritizing our Prehab X member questions. And at the end, if I get a chance, I'll go through some of the other questions as well. I see some comments piling up over here, so feel free to ask away. So basically, what is hip impingement? So the hip is a ball and socket joint like this. And when you're going into hip flexion, hip internal rotation, or hip adduction, what's happening is the ball is hitting the socket. And so it can create symptoms. There's things like clicking, catching, or just deep ache in the hip joint, which can be created from hip impingement. And so there's two different main types. One is CAM, one is a pincer impingement. CAM is a little more prevalent in males. Pincer is more prevalent in females. So once you've been diagnosed, usually it's a clinical plus an MRI diagnosis. So once those two match, what you can do is intervene. Ideally, you have a skilled physical therapist that you go to, in which you can find a specific plan of care. But my approach is this. So I look at things in this progression. First, I look at alignment, then mobility, then stability, then dynamic stability. I'll explain what I mean by those. So first thing is alignment. For example, what may be happening when someone goes into like a squat position, if they have too much anterior pelvic tilt, meaning the pelvis is leaning too far forward and the back is arching a bit, what can happen is you can create that abutment quicker than usual. So that would be more of like an alignment issue. So what you would address at that point would just be lumbopelvic control. Specifically working on the control in itself may be enough to reduce symptoms and allow someone to squat, deadlift, lunge pain-free again. That would be the quick fix. And that's the first thing that you want to address, because that can be addressed sometimes within minutes. The next is looking at basically the pull of the pelvis. So the muscles that pull the pelvis into an anterior tilt would be the the hip flexors in the front, or the erector spinae muscles in the QL in the back. So looking at the length of those and making sure those are adequate and have the adequate flexibility that you want. So that in itself can be addressed by mobilizing the tissue. Or it may be that the glutes and the core in the front are not doing their job. So basically the pull of the hip flexors and the erector spinae QL may be creating this anterior tilt. This is what's also known as lower cross syndrome. So if you look at and find some muscle imbalances, that can be addressed with the alignment issue. But let's say alignment's good. What you want to go to next is mobility. A lot of times what's limited with someone that has FAI is hip flexion, hip adduction, and hip internal rotation. So those three things are all closing the joint, and when put in those positions, oftentimes create some irritation. And you want to improve mobility here, but you want to be careful, because a lot of times people will be like, oh wow, I'm limited in hip internal rotation. Let me just jam my hip into internal rotation until I improve that position. But you have to be careful, because you can create more harm than good if you really push into an uncomfortable position and create some inflammation that may create more of that those osteophytes that are already creating your symptoms. So you need to be strategic with this. But if you can improve mobility with hip flexion, hip internal rotation, or hip adduction, which we have a ton of exercises regarding, address those. The next is stability. So what may be happening is you may be putting too much stress on passive structures, being the joint itself, because you don't have the active stability. So basically the shock has to be absorbed via passive or active structures, and if you don't have the active strength, being the muscles around the hip joint, you may be putting excessive stress and strain on those passive structures. So it's something that can be addressed, and it's not just the muscles in the front, which I'm talking about, like the hip flexors. It's everything. It's the glutes, the even the TFL, those deep hip external rotators, the adductors. All these things will help stabilize the hip, so that you don't have to be putting so much stress and strain on the passive structures, which may be creating hip impingement. So then the next step is dynamic stability. This is the important one. This is how you're going to get back to higher level function, because once you address these little impairments, that's okay and all, but not until you actually teach yourself how to move in a proper position, avoiding this irritation, will you actually go through your lifespan without having to put yourself at risk for this irritation again. Also, another thing to note with stability is end range holds. So you can stretch all you want, but they say passive interventions yield passive results. So what that means is you want to actively be able to put yourself in a certain position. So if you have great hip flexion passively, cool, but can you actively hold that position? If not, that's something that you may need to work on. I know FRC harps on a lot of stuff regarding end range holds, so look into some of that stuff if you're limited with your end range hold position. So that in itself will allow you to actively get in those positions, which is really how you maintain mobility. When you passively stretch, it gives you a window of opportunity for you to use that motion actively. So you want to capitalize on that and work on actively holding these positions. That way, long term, you hold that position or hold that mobility gain. Okay, so dynamic stability. This is where it gets fun. So you want to start loading, but you want to be strategic, because you know that if you go into too much hip flexion, like going into a deep squat, that may irritate you. So you can start loading with your trunk more upright with less hip flexion, because you know that hip flexion, especially with a load, may irritate you. So this is when you start with things like front squats, lunges, where you can keep your trunk upright and you don't have to lean so far forward. And once you start feeling comfortable with that, you can start going into a little more of a hip flexed position. This is when something like a high bar squat may be appropriate, where you don't have to lean so far forward. And then eventually, once you start feeling comfortable with that, you can start going to a low bar squat or a deadlift. These are things that will require a little more hip flexion, but you want to be strategic. So you load first with things that require less hip flexion, and then as you feel more and more comfortable, you start loading into a little bit more and more hip flexion. So that's basically the gist of it. A quick 10-minute breakdown of how you can progress someone from an alignment perspective, moving to mobility, working on hip adduction, hip flexion, hip internal rotation. Then stabilizing, making sure that they can actively hold the end range of those positions, in addition to working on those little muscles around the hip joint, so you don't have to stress and strain the joint itself, and you can focus on developing active stability. And then working into dynamic stability, where you're doing things like front squats, lunges, and then progressing into a high bar back squat, and then into a low bar back squat and deadlifts. So let me know if you guys have any questions. I'm going to prioritize Prehab X members first. Okay, and then I'm going to go through Instagram. I saw a few things here. Cool. If there's no specific questions regarding this topic, my shoulder is in pain. Okay, so someone asked, Miss Osteopath asked about cam pincer combined. Honestly, the literature a few years back showed that up to 85% of hip impingement is combined. However, I saw a new article that came out this year. I have it pulled up actually, that talked about how what they're finding now is only 2% is truly combined. That's by Rave Endran et al. 2018. They found only 2% from this study, which was a prospective longitudinal cohort study, found that only 2% had a mixed morphology. So who knows? It's not a big deal unless you're going under the knife anyways. You're gonna address a cam and pincer very similarly. All the difference is a matter of where that osteophyte is. Cam is more on the head a little bit more. The pincer is more on the acetabular rim itself / labrum. So stick to stuff regarding the topic. And if you had a recommendation with topics, we are prioritizing Prehab X members, which we have a private group. And if you're not sure and want to try it out, we have a free 10-day trial. And that way you can go through at least one of our weekly live Q&As. What is not recommended if HAP impingement and OA? Kings Road, London, I'm not exactly sure what you're asking. Thanks for the support, guys. A lot of likes here. Talk about labrum. Basically, what I talked about had a lot to do with the labrum itself as well. Cool. Shout out from Portugal. Hello, Greece. How many physiotherapists here? We are 3 physical therapists in America, but looks like a majority of people actually are rehab professionals here. Cool. If there's no other specific questions regarding this topic, I'm gonna log off. OA equals osteoarthritis, right? I mean, the interventions can be very similarly approached when I'm talking about reducing hip flexion to maximizing hip flexion in terms of the dynamic stability. Okay, awesome, guys.